Okay, so here's our agenda for today. First, we're going to start out by defining a little bit of what self-care and mindfulness is. We're going to be then talking about the purpose and importance of the study, the one that's in the reading for today. We're also going to get into what secondary traumatic stress is, and also mindfulness as self-care, and also the outcomes of our study. Later on, we're going to be talking about policy and clinical implications for social work practice, and we're going to end with an activity that all of us are going to do to improve our own self-care and practice. All right, so thank you, all of you, for participating on the discussion board and giving your feedback of how you think of self-care and mindfulness. You know, one of the things I noted on the discussion board is that a lot of you had related self-care to mental health. I do want to kind of speak to this a little bit because you're not necessarily wrong, but the two of them are not mutually exclusive. There are differences between the two. And it's important that we kind of just sort it out a little bit. You know, when I think of mental health, I think mental health includes emotional, psychological, and social well-being. And our mental health affects the way that we think, feel, act, make choices, and relate to others. And our mental health is more than the absence of a mental illness. I would say that it's essentially our overall health and quality of life. Now, where I think that you guys had really kind of come in and brought in the self-care piece, and here is where you're correct, is that self-care can play a role in maintaining your mental health and help support your treatment and recovery if one or you were to have a mental illness. But self-care is a little bit different than mental health in itself. Self-care means taking the time to do things that help you live well and improve both your physical health and mental health. So when it comes to your mental health, self-care can help you manage stress and lower your risk of illness, for example, or increase your energy. And even small acts of self-care in one's daily life can have a big impact. Now, the interesting thing is that in today's lecture, via the study that we're going to look at, and also for the field of social work as a whole, because we deal with a lot of different human experiences that can be emotionally taxing, and maybe even trauma, which is, as you guys know, part of the article and in the study. Self-care is so important. And we're going to talk more about self-care and the role in social work and all of that in a little bit. I do want to just put out there that I think most of you had acknowledged mindfulness, and we're going to also kind of flush out that definition a little bit more, in particular as it pertains to the study. But in brief, mindfulness is the quality or state of being conscious or aware of something, right? So as much as mindfulness is a fashionable term in literature, it's not something that we have to, acquire, right? Just by being aware right now here that we're present, that we're conscious, we're aware of something, that we're mindful, right? All right, so let's jump into today's article for today. I appreciate that all of you have responded to the poll that was on Blackboard of whether or not you found that this article was helpful for deepening your understanding around self-care practices and social work. I appreciate it because it's true. This article illuminates some really important concepts in our field. It illuminates the importance of having awareness of our thoughts, our feelings, the impact of our level of satisfaction in work, or in other words, our work setting, and our experiences of secondary traumatic stress. This article, as you know, was an article that examined the relationship between level of mindfulness and secondary traumatic stress amongst licensed social workers in New York. And those social workers were employed in a variety of different agency settings or private practice settings. And it was quantitative in nature, meaning that it was using standardized scales, and it was a very large sample, right? It was over 150 people. Versus qualitative, right? Qualitative research is more of seeking an in-depth understanding of a social phenomenon, right? This was quantitative, not qualitative. The scales that it did utilize Well, first there was a questionnaire that was seeking demographic information and professional characteristics of the participants. Then there was also the cognitive and affective mindfulness scale, CAMS-R, that examined level of mindfulness, which we're going to talk about a little bit because that is also a variable. It's a little bit hard to define and examine. We're going to then look at the Minnesota Satisfaction Questionnaire, which was utilized to determine and assess workers' level of work-related satisfaction, and secondary traumatic stress scale, right? Examining the workers' level of STS in the field. Why was this study so important? Let's think about that. All of you found that it was important on the poll, but why was it important in particular? Well, why it was important in particular is that not only, like we were just talking about, illuminate some of the important concepts when it comes to worker self-care and the importance of our own sense of awareness in the field and so forth, but it was particularly important because it brought to the forefront that of all mental health professionals in the country, nearly 2/3 are social workers, and that in the recent decades that the work of mental health workers has been increasingly dedicated to providing services for clients with traumatic memory and traumatic symptomatology. Now, this is really important. If social workers comprise such a substantial portion of the mental health workers in the United States, and they're working with clients that have more traumatic symptomatology, well, there needs to be more awareness of how they're experiencing these traumatic effects, right? This is why it was so important, because one day, maybe now, if it's happening in field at all, if you're having clients that have traumatic symptomatology, is it having an effect on your sense of self? Or perhaps in terms of even other things like STS, secondary traumatic stress, right? Some research, just a note here, that the exposure of general population to traumatic events on a national level is relatively high. For instance, and this was captured by Escalona in 1997, 84% of psychiatric inpatients identified at least one traumatic event category with symptoms consistent with PTSD. Now, I'm just going to say it one more time. Researchers found that 84% in their study, in their analysis, 84% of psychiatric inpatients identified with at least one traumatic event category consistent with PTSD. Now, that's pretty high. And additional studies identify that between 82% and 94% of the outpatient mental health population, this is like folks that are working in clinics, right, or community-based settings, that between 82 to 94% have been exposed to at least one lifetime trauma, and 31% to 42% identified with criteria consistent with PTSD. So these rates and populations are a mere fraction of individuals serviced by mental health workers, but these distresses certainly place workers in a position of possibly developing STS. I mean, this is why it's so important to have awareness over the variables that took place in the study, because the population that most social workers service do have relatively high rates of trauma. Other researchers, as you see on this slide here, have noted that the mental health profession is characterized as one of the most stressful and emotionally demanding occupations. What do you think of that? I guess it may depend a little bit, right, on the type of work and the hours and some of maybe the other demographic and professional characteristics that the study looked at. But it's an interesting statement, and I wonder what you guys think about that. And here, another bullet point that we have on our slide is that research has shown that workers engaged in direct services with populations that have traumatic experience are at risk for developing work-related psychological distresses, such as increased anxiety, depression, mental fatigue, and strained interpersonal relationships. So we see that the importance of this study really brings forth this need here to deepen our understanding of the variables in the study, and in particular as it may relate and apply to our own understanding and potentially our practice if we're in field, or certainly after we graduate. Okay, so we have an overview of the study that was conducted in the article that we read for today. Let's get into secondary traumatic stress. Secondary traumatic stress, as we know, was such an important variable in the study. It was a dependent variable, and it was an important one to look at as it related to the workers' level of awareness and satisfaction in their work. In order for us to even get into secondary traumatic stress, we have to kind of spend a little time in talking about trauma. Trauma is such an critically important term to really flesh out and to think about, because without understanding trauma, we're not going to be really able to understand secondary traumatic stress. And then after, we're going to look at a couple of other terms that are kind of related and important to know in our practice. So when you think about trauma, what comes to mind? Think about it. When you think about trauma, what comes to mind? Probably something really horrible, something bad, something that maybe scarred the person psychologically. If you thought about the word scarred the person psychologically, you're right. So the word trauma actually comes from the Greek word to wound. So it's like a psychological wound. And it really became prevalent in our literature, clinical literature, in the 80s with the third edition of the DSM. And essential features of trauma at that time was severe psychological trauma, right? Like maybe people returning from war and having severe psychological trauma. And this type of trauma got known as post-traumatic stress disorder, right? Or PTSD. And an important feature of trauma is that an individual may experience trauma either directly or indirectly, and it can occur without actually being physically harmed or threatened with harm. I'm going to say that one more time. An individual may experience trauma or either directly or indirectly without actually being physically harmed or threatened with harm, right? Currently, the definition of trauma has evolved, and it includes learning about unexpected or violent death, serious harm, or threat of death or injury experienced by a family member or close associates. And over the decades, right, throughout the decades, since the 80s, right, the effects of extreme traumatic stressors have been well documented in our literature. And it should be noted that in the literature, the effects of traumatic stressors extend well beyond those directly affected by the trauma to the individuals that are indirectly or secondarily affected by close contact with trauma victims. So you guys see where I'm going with this? Is that as much as trauma, and it's in its own classification, PTSD, oftentimes includes individuals that have experienced events directly. Individuals can experience trauma on a secondary basis, right? And the effects of secondary exposure to an extreme traumatic stressors are essentially those affecting the individual, that same as those effects that affected the individual that experienced the trauma in the first place, right? So the individual, in other words, if we hear about traumatic content, we didn't experience it on a first-hand basis, but if we hear it on a second-hand basis, the effects could be similar to those that are experienced on a first-hand basis, right? This is the second-hand effects of trauma. Now, let's look at our slide for a moment. One really important researcher in the field is Charles Figley, and he's the one that actually introduced the term in 1995 of secondary traumatic stress. And how he came about with this term is that he was working with mental health professionals and their experiences of trauma. And throughout his observations, he observed that workers appeared to vicariously experience trauma, and he concluded that if a worker was exposed to a high level of traumatized content or individuals or clients, that the worker had experienced what he called an empathic orientation. And when the worker related symptoms consistent with vicarious trauma, for example, wanting to avoid the client that they were working with, flashbacks of the client's trauma, and feelings of possessing intimate knowledge of the client's experience, the worker was particularly vulnerable to the development of secondary traumatic stress. What Figley found at that time was that STS had the same symptoms as PTSD, except that the exposure to knowledge about the traumatizing event experienced by the significant other is associated with the set of STSD symptoms, and PTSD symptoms are directly connected to the sufferer, the person in harm's way. Does that make sense? So when we think about secondary traumatic stress, it's more on a second-hand basis, but the symptoms are the same, if not similar. And for workers, Figley concluded at this time, and this was really the advent of secondary traumatic stress in our field and literature, is that for workers, it was essential to find ways to reduce stress and increase self-care in order to protect against psychological disturbances that compromised the quality of service, right? Because look, imagine if you are a worker in the field and you're experiencing symptoms consistent with STSD, and you're not necessarily aware of it, but you're experiencing it. Well, it's not only going to affect you, it's going to affect your client, right? If you feel that you're going to, it's going to be hard to connect and to do your work, well, your client is going to feel the same. So the practice of self-care at this time also really came forward, and it was noted in research as one of the top ways to buffer the effects of symptoms associated with STS. Okay, I also want to spend a little bit of time because there's similar terms that come up in the literature, and they've been used to address this phenomena of induced trauma, but they're slightly different. So if you guys have come across perhaps a term of compassion fatigue or burnout, they're similar, and it's important to understand STS in its own right, but it's also important to understand what burnout and CF, compassion fatigue, is. So compassion fatigue, similar to burnout, may challenge a worker's ability to render effective services, and maintain personal and professional relationships. And essentially, compassion fatigue is a natural consequence of working with individuals who have experienced extremely stressful events. It develops as a result of the worker's exposure to their patients' experiences combined with their empathy for their patients. CF, compassion fatigue, like other forms of fatigue, reduces the worker's capacity or interest in bearing the suffering of others. And it's characterized as a state of tension and preoccupation with the traumatized patients by re-experiencing the traumatic events. Now, researchers assert that the symptoms of compassion fatigue impact all areas of the clinician's functioning, including affective, behavioral, and cognitive, and as a result, depression, irritability, interpersonal, withdrawal, and somatic symptoms may develop. But in contrast to compassion fatigue, which is sudden and acute, burnout is a gradual wearing down of the provider by their feelings of being overwhelmed by one's work and being incapable of effecting positive change. Emotional exhaustion, depersonalization, and a reduced feeling of personal accomplishment characterize burnout. And ultimately, burnout develops as a result of general occupational stress and is not used to commonly describe the effects of indirect trauma exposure. Now, where does STS fit into this? Is that STS is a bit different in a sense that it correlates more to the person's experiences of indirect trauma, secondhand trauma, right? So CF and STS are similar, but the effect on the individual is different, and the content, the exposure of the traumatic information is different, right? Okay, so back to our study. Our study here in the article looked at mindfulness as a means to self-care. So you may say to yourself, wait, mindfulness as awareness? How how can awareness be used as self-care? Well, yes, awareness is synonymous with mindfulness, but mindfulness itself actually comes from a larger background, if you would. Mindfulness is derived from meditation, which people also use as a means to self-care. Meditation, as some of you may know, had originated thousands of years ago, right, in India, and it was oftentimes associated with religious reasons, right? People may have meditated part of their religion, and maybe Buddhism and Hinduism, and it's still practiced today like that. In perhaps certain religious beliefs, it is a vehicle that's used to attain higher levels of concentration and transpersonal levels of development. Now, in the past couple of decades, meditation also gained popularity in psychological and medical literature as an effective clinical intervention to reduce stress and improve certain medical conditions. And within the literature that looks at meditation, they've also kind of extrapolated the term mindfulness in the sense that on one hand, it can be used fashionably to describe meditation practice, and also that it's a quality, it's a state of being, that it's the awareness that emerges through paying attention on purpose in the present moment and non-judgmentally to unfolding of experience moment to moment, as Jon Kabat-Zinn, a huge pioneer in the field, stated. And with that in mind, mindfulness-based meditation, which is a type of meditation in itself, is a process by which the meditator becomes and practices their awareness, and they're aware of mental activity as an observer, and they're not necessarily trying to make an effort to modify it. And in a similar fashion, like mindfulness-based meditation, yoga has also been used as a vehicle to cultivate mindful awareness. Now, in this study, we use the CAMS-R, which is a scale that tries to not look at the meditation per se, but the quality of the individual's awareness, right? So essentially, if a participant in the study naturally, let's say, had higher levels of mindfulness, that's suitable. Now, the study within the professional and demographic questionnaire did look at yoga and meditation practices, and you guys know that we're going to look at that in a little bit as well. But that is mindfulness in a nutshell. So let's kind of move forward and move into the study if we could, and then we're going to take a look at the results and the implications. All right, so let's look at the study a little bit more closer if we could. So the study looked at 152 licensed social workers. The study examined the relationship between higher level of mindfulness and lower levels of secondary traumatic stress among social workers. And the type of study that was proposed, as much as it was quantitative in nature, it was also a correlational design based on social workers' self-reports of conditions of work and their experiences of STS. The data was obtained by various questionnaires and standardized instruments, right, that have been validated and used in research before. First, we have the demographic questionnaire that had professional characteristics, and we're going to look at some of those results in a moment. Also, the CAMS-R, the Cognitive Affective Mindfulness Scale, revised edition. I think an important note here, and I kind of referenced it earlier, is that mindfulness, because it's a quality, it's a state of being, it oftentimes is difficult to capture in literature. The CAMS-R does a nice job, and in this study, mindfulness was both a independent and dependent variable. And just a little bit about the CAMS-R, it's a 12-item Likert scale measure that is written in ordinary language, so it's not kind of too abstract or whatnot, and it does not require training in meditation. It can be used for a wide variety of samples, right? So it's really a great tool to help measure mindfulness, in particular, as the instrument it prepares individuals is looking closer at their ability to regulate attention, their orientation to present or immediate experiences, awareness of experience in general, and kind of an attitude or acceptance or non-judgment towards experience, if you would. And over time, the CAMS-R has demonstrated acceptable internal consistency and evidence of convergent and discriminant validity, right? So it's totally valid to use in literature. The Minnesota Satisfaction Questionnaire was used to kind of look at job satisfaction. And job satisfaction in this study also was an independent variable. And it, of course, by its nature, job satisfaction is a subjective response to how the participant feels about his or her work role, right? Why this is important, though, is that job satisfaction has been found to correlate with higher levels of self-esteem, increased positive attitudes towards clients, and greater satisfaction. Obviously, we're looking at STS in here, right? We're looking at STS, seeing if it plays an important role in the study in the individual's ability to regulate their experiences of STS. And within this particular study, the STS scale, and there's many of them out there in terms of trying to assess and determine if an individual is experiencing STS. This STS scale that was utilized in the study encompasses 3 subscales that represent predominant features of PTSD, which is important. Those predominant features are intrusion, avoidance, and arousal. And the questions of the scale that correspond to these domains are noted in the scoring of the scale. Okay, and lastly, again, more about the professional characteristics and demographic information. We're going to look at all of the results of the study in a second. Okay, so here we have some of our results from the demographic information. This is what our gender profile looks like of all the participants. 74%, which is quite a number, 74% of participants identified as female, and a mere fraction identified as male, and a few didn't respond. So that's interesting. I wonder how gender plays a role here in our examination in the study, right? All right, so here we have our kind of salary range of the participants that took place in the study. As we can tell, within the $46,000 to $55,000 range, of the vast majority of participants identified in that range, and then we have some on the outside of that, around 36 to 45, and other 56 to 65. This is like the bulk of the participants, which is an important factor, right? We want to look at the salary, how much are they compensated in terms of their experiences at work, and does that offset at all their experiences of trauma? So who are these participants, right? We know that there's 154 of them in the study, but here we got it, right? Let's look at this. It looks like the majority of them work in, or identify that they work in mental health. A good amount of them work in the schools. We also got substance abuse clinics, and communal agency, right? To a lesser degree, some of the participants identified as working in the aging area of social work, in a hospital, child protective services, and to a much lesser degree, administration, college counseling, and private practice. Okay, so we know their gender, we know the areas in which they work in, we know their salary. Now, how many of these folks really identify in that they're working with trauma? Here we have it. So it looks like the majority of folks, there's a bit of a dispersion here, but with the majority of the folks that say that they identify in their work 25% or less. Some of them identify, a good portion of them identify as 25 to 50% of their work is trauma-based, and then a pretty high number, 50 to 75% of folks identify that their work is quite a lot of trauma. So we have quite a range here in terms of how many folks identify with trauma in their work. So this is going to be interesting as we continue. Here we have the secret weapon. How many of these individuals, how many of these social workers that took this study participated in some sort of self-care? Well, if you look at that orange, about 70% of them surprisingly identified as participating in self-care. 30% said no. So I'm wondering, how does all this going to start to factor out? of those participants that participated in self-care practices, some of them actually participated in yoga and meditation. Of yoga, 39% said yes, 61% said no. Of those that meditated, 40% said yes, and 60% said no. All right, so let's look at the outcomes for this study. So the first hypothesis, as you guys read in the article, was that it looked to see if the higher level of mindfulness was correlated with a higher level of job satisfaction. As you were reading the study, or even before, I'm wondering what your thoughts were. Well, the study found that hypothesis 1 was indeed supported. There was correlational significance observed between study participants 51 and over and those between the ages of 26 and 30, as they evidenced significantly higher levels of job-related satisfaction scores. The findings also indicated that mindfulness in those who practice yoga also evidenced significantly higher job satisfaction scores. That's interesting, huh? That those that indicated higher levels of mindfulness and practice yoga were more satisfied with their work. So in light of this, the study tends to further support that a relationship exists between mindfulness and job satisfaction. Another hypothesis in the study looked to see if there was a positive correlation between the length of time practicing meditation and the worker's level of mindfulness. The longer one practices meditation, the higher the level of mindfulness. So this wasn't supported, interestingly enough. And this result is actually consistent with previous research. Researchers May and Donovan in 2007 found that participation in yoga practice and to some extent to meditation practices did not appear to enhance levels of mindfulness. All right, moving on to hypothesis 1B. There was a positive correlation between the length of time practicing yoga and the worker's level of mindfulness. The longer one practices yoga, the higher the level of mindfulness. Correct. This was indeed supported. And it was demonstrated in the study. This may have happened for a few different reasons. Perhaps yoga practitioners may have had some sort of experiential background that allowed them to integrate clinical feedback more immediately and effectively. And perhaps the quality of practice time is potentially as relevant to the outcomes of the quantity, right? This is one of the issues that deserves future consideration and research. All right, last but not least, hypothesis 2. The greater the worker's level of mindfulness, the lower the level of STS. Drum roll, yes, indeed, the findings of hypothesis 2 were supported in this study. All right, so the results of the study have some important clinical and policy implications. It builds on the notion that for mental health workers, exposure to SES places the worker at risk for burnout and psychological distresses that compromise service and worker effectiveness. Now, building in the body of knowledge that exists, clinical evidence suggests that STS can be managed or prevented with a combination of personal, professional, and administrative or policy interventions. And also, there are implications for policy here, and that this study may help aid in the prevention of STS and helping keep mental health workers providing quality services, program development, and so forth. All right, so in conclusion, the primary purpose of the study was to identify the relationship between mindfulness practice and job satisfaction and the dependent variable of STS, and it found that indeed the higher levels of mindfulness are related to an increase in job satisfaction and lower STS for social workers. So a big takeaway here is that, and it's supported by the study, is that mindfulness practice, deepening our awareness, whether it's through the vehicles of yoga or meditation to some extent, can be used as an adjunct to social worker self-care practices and can help the worker to be more present, accepting, and effective in their relationship with their clients. All right, guys, before we end, we're going to end with a self-care planning form. Now, this is obviously going to be uploaded into Blackboard on the assignments, but I just want to go over this quickly, and you can do it, and I'll make some notes on it later on. Is that you'll see that here, this is a self-care planning form, and this is just an example. You can look at it deeper on your end after we finish today's lecture. It's going to be posted on Blackboard as well. It has a few of the areas in terms of self-care. We see physical care, psychological care, so forth. It outlines specific goals and accountability measures. So you can use this as a reference. It's going to be posted on Blackboard. And what I'm going to show you in the next slide is how it's going to look for you. So you can see this as a reference, and then you can model it and then do it for yourself. And once you submit it, I'll give you some feedback on it. All right, so here we are. This is the self-care planning form. This is what you're going to see on Blackboard. By Friday, I would like if you guys can take care of it, look at it, start, really try to understand it. And this is something that will help you to deepen your own self-care and build a sense of awareness as it relates to your own thoughts and feelings. And when you go out there with your work, in social work practice, so you can stay resilient. Thank you so much for taking the time to look at my presentation today. It's truly an honor to be a part of this process, and I look forward to hearing from you soon.